I think HPV is nothing new. It's been used in many countries, but why we thought it would be good to have you as agents of change is what what we've realized has gone on in many other countries. When you are introducing something new and you don't let the population know exactly what you're doing and the benefits, then it creates problems. I think the long and short of HPV is the fact that it prevents cancer, and therefore it has to be good if it prevents cancer. Let me give you a few statistics that you probably may have access to, and probably Dr. Hamilton will also allude to some of them. The main purpose for HPV is the prevention of cervical cancer. That's what I just indicated. And that HPV also prevents against genital warts in both females and males. And for this purpose, HPV prevention, the vaccine will also, for this phase of the HPV prevention, the vaccines will be given to girls between 9 to 13, and Dr. Hamilton will explain it more. Data from WHO clearly identifies cervical cancer as the second most common cancer in women of reproductive age group. And if it is, and there is something that we can use to prevent it, then it's high time that we get onto using it. According to PAHO WHO, 83,000 women were diagnosed with cervical cancer, and almost 36,000 died from this disease in the region of the Americas. When I say region of the Americas, I'm talking about Latin America, North America, and the Caribbean. If this trend continues, the number of deaths in the Americas is projected to increase by 45% by the year 2030. So it's imperative that we do something about it. Cervical cancer mortality rates are 3 times higher in Latin America and the Caribbean than in Northern America, highlighting inequities in health. And approximately 70% of cancer cases could be avoided through HPV vaccination of adolescent girls. 70%. And we have to think about the losses to the community, the losses to family, the economic loss in terms of taxation that one will not get because the person will not be economically viable. 70% of cancer cases can be avoided. In terms of Latin America and the Caribbean, Guyana cervical cancer rates was 46.9 per 100,000 Guyanese population, and the most affected was the Afro-Guyanese. I think this is something that I think needs more study. I don't want us to just quote the figure that Afro-Guyanese are more likely to have cancer of the cervix from HPV. It needs to be looked at more, because there could be some spurious factors out there. So we need to look at that. But the data that we have from 2003 to 2012 indicates that. So this is something that we need to seriously consider. The Ministry of Public Health Guyana conducted a review of cancers over the 10-year period. The data gathered in this study is consistent with the WHO statistics presented, with cervical cancer being the second most common cancer in the population of Guyanese women. In Guyana, during the period 2003 to 2012, like I said, Guyana recorded 6,518 new cases of cancer, for an overall cumulative incidence rate of 867.7 per 100,000 of population. Now, let me put this in perspective, and I don't mean to confuse you, but I will. If you look at the age-standardized death rate for suicide, it used to be 42.3, and we were crying foul. It's too bad. Now, if you look at the standardized incidence rate for Guyana, the other one was standardized death rate. That's for suicide, 42.3, and it's one of the worst things that we can think of. If you look at the standardized incidence rate for cancer of the cervix, it's 867. It's out of this world. I think we need to do, not cancer of the cervix, that's all cancers. I think we need to do something about it. The pediatric age group, constitutes about 2%, and I think most of us know that fact already. Also, 2/3 of all cases of cervical cancer were women under the age of 60 years, with the 15 to 39 years age group having the highest percentage. Now, one problem that I've always had in terms of cancers and people who allude to wanting to do more in cancers, and I met one group just last week. They said, well, we are doing screening. I said, fine. What do you expect from PAHO WHO? Well, there's a conference in Japan, and we're wondering whether we can go. I said, what does that have to do with screening? That's one. And then I asked them, so the people that you screen, if you screen somebody and the person is stage 3, getting to stage 4, and when I say stage 3 and 4, they are the worst areas that normally, once you've reached stage 3 and 4, usually we just have to begin to think about palliative care, something to make you feel a little better or die in dignity, sometimes. And the argument was, well, even some of them, we do the stains, and now GPAC wants to charge us for reading the stains, and therefore we have over 300 slides that have not been read. I said, do you know that you are killing these women faster than they would have died, even if they had the cancer? And I've said this over and over again, research that was done in Harvard in the 80s showed that if someone knows their status and you do nothing about it, they are likely to die faster than if they didn't know their status. So I'll give you an example. If you stage 2 people with HIV or AIDS at the same level, same age band, same level, same stage group, and you tell the 2 people, you tell one person you have AIDS, but then you do nothing about it, and the other person, you don't tell that person that the person has AIDS, so the person doesn't know. Research in Harvard showed that those who didn't know their serostatus lived 18 months longer than those who did. So there's no point telling someone that they have a condition when you don't do anything about it. And why am I telling you this? Because a lot of people are doing screening and not going forward with it. So if we have a vaccine that will prevent people from even getting the cancer, then we cut all those out. What's the point in telling someone, well, you came for a pap smear and we've taken the slide, but after 2 months we still don't have anybody to read it? I think that is unconscionable. In 2015, a national assessment of cancers in Guyana was conducted, and the findings guided the identification of strategic lines of action. I won't bother you with that. So, ladies and gentlemen, I think, and it's good that we have a few gentlemen here. Let us remember that HPV prevents cancer, and that's the issue that we want out there.
What is HPV? Human papillomavirus, as most of you know. And this, according to research, is now considered as the most common sexually transmitted infection. More than HIV, more than syphilis, more than gonorrhea. Most of the HPV infection, however, causes warts. Some of the warts that you see on your skin are caused by HPV. How you're able to distinguish it, I will show you a picture later. That gives you an idea of what the warts look like when it's caused by HPV. Now, HPV have 150 strains. And more than likely, if you take most of the persons in this room and you swab them to see if they have HPV, most of us will be positive for HPV, right? So that's something for you to think about. What are the most common strains that we have in focus? It's 16 and 18, but notwithstanding, there are also 6 and 11. Now, 16 and 18 are the strains that causes cervical cancer, and that's according to our research and all of the research that would have been done over the years. Now, how do you get HPV? Besides sexual intercourse, You can have HPV by direct contact with the virus from broken skin. That means any part of your body, if there's a cut, there's a bruise, and you're in contact with the virus, you can be infected. It also can affect a baby during the passage through the birth canal during delivery from the mother if she's positive. As I said before, almost 80% or more sexually active adults have some strain of the virus. And the highest percentage of individuals who the virus are found in, as Dr. Adukro alluded to earlier, are found within Latin America and the Caribbean. If we look at any other part of the world, the amount is not so enormous as what we have in our little region. This is what it looks like when you have, if you see warts like that on the skin, more than likely the cause is HPV. It looks like a cauliflower. You see what the normal cervix looks like? It's nice and pink, it's shiny. But then we have the picture that is just at the bottom, to your left. That is called a low grade. That is when we start having changes just on sight. When we go across the high grade, it means that it would have affected a little bit more. The cells are more mature, the cancerous cells are more mature. Then we get the actual cancer. That is still okay where it is, you can do something about it. But when that takes over everything and starts moving, that is when the challenge starts. And that's when it makes it more difficult, your management and what happens to the patient after. What are symptoms? And this is for you, and this is for your neighbor, and this is for anybody. Your wife, and well, if you have a daughter around that age. What are the symptoms you need to look for to tell somebody that you should go and see a doctor? Most cases, the unfortunate thing is, when it's early, you know nothing in most persons. Absolutely nothing. But as it progresses, persons can complain of bleeding after sexual intercourse. If you are at the age where you would have already entered into menopause, you can have bleeding after menopause. Menopause, as we know, is when your period or your menstruation stops. Any bleeding after that is abnormal. We're not saying all bleeding after menopause is cervical cancer, but it's one of the things you have to think about. Unusual vaginal discharge with or without blood. Now, most gynecologists, most doctors will tell patients and women, you need to know your body, you need to know what it smells like, all of that. You need to know what your secretions look like so that you can identify when something is going wrong and you can actually seek assistance. Swelling to one or both upper thighs. That is where we have the lymphatic glands, and those are triggers that tell you that something is going on. Even if you don't have any other sign or symptom, you find large lumps at that area, you should check it out. Pelvic pain or discomfort, and for most other cancers, we have weight loss. What are the facts about cervical cancer when we look at the Guyana context? As mentioned before, it is the second most common cancer in women, and this speaks to the Guyanese women also. The number of cases of cervical cancer is actually increasing. Of the data that we reviewed from 2003 to 2012, it was identified that 4% of the cervical cancer was detected in stage 1. Stage 1 is where you can do something about it. Now, if we only have 4% in stage 1, that means 96% of all the other cancers were detected outside of that stage. What does that say? At least a large percentage of those detected outside are persons who probably did not live because it would have been detected at stage 4. 27 out of every 100,000 of our population, women die of cervical cancer every year. We have 750,000. You multiply 27 by 7.5.
But this is only for women. So women would be
of
about
the population. That should be, yes.
Half.
When you look at that now, you're going to see how many persons are actually dying. When you look at, we're small. So think about 27 out of 100,000. That's a lot. When you look at the numbers combined, it's a lot. 2/3 of all of these cases were women under the age of 60. And the age group that we found most at risk were 15 to 39. At risk means you're at risk for having the infection and developing cancer. That is us in here, right? Now this is just an annual incidence of cervical cancer. The numbers are very small, but most of it is somewhere between 80 to 120, which is the highest number of persons per year from 2003 to 2012. The other data, of course, if we're increasing every year, will obviously be a little higher than that. How can it be prevented? To date, the one most effective way of preventing cervical cancer is by using the HPV vaccine. As Dr. Adukro said before, 71 countries in the world have already started using the vaccine. Some of them are more radical than others, because I read Mexico has made it mandatory that all girls receive it. Of course, that's not the same in Guyana. It's a voluntary activity. But it's important to recognize that the one most effective way is just a vaccine. A little stick and that's it. Prevention for the rest of your life. But if you're beyond the age where you can have the vaccine, we have screening that's available, and it's what we promote. Looking at cervical cancer is a comprehensive activity. We can't just look at one aspect of it, because it transcends throughout the life course. So you will have persons who are eligible for the vaccine, and there are those who are not eligible. And there'll be those who would have already had cancer. So in looking at it in that spectrum, the girls can have the vaccine. If you're above the age, then you must do regular screening. Screening is determined by what is presented after your first visit. If you have lesions, they will tell you to come back at a shorter time than if you do not. Right? And what is available for screening? There's a pap smear and there's the VIA. In other parts of the world, there's also the HPV testing that is done. Guyana is hoping in the future to be able to have that available. Currently, there's no diagnostic tests for men. So you're still in that area where, we're unable to say what is going on with the male population as it relates to HPV. Now, what are the vaccines that are available? There are 3 types of vaccines available. There's the Cervex, there's Gardasil, and there's Gardasil 9. Cervex looks at 2 strains of the HPV virus, which is 16 and 18. Those are the ones that causes cancer. Gardasil looks at 4. Gardasil is quadrivalent. It looks at 4 types. That looks at 6, 11, 16, and 18. 6 and 11 causes the warts, genital warts. 16 and 18, as we know, causes cancer. Gardasil 9 looks at 16, 18, and as you can see there. So it's more of a wider spectrum. Guyana is looking at introducing the Gardasil, which looks at 4 strains, 6, 11, 16, and 18, for genital warts as well as cervical cancer. Side effects of the vaccine. This vaccine is like any other vaccine that we give to children. You can have fever, there can be mild swelling and tenderness to the site where you receive the vaccine. Some patients complain of a mild headache. You can have an allergic reaction, and this is the same with any medication or any food. You can have an allergic reaction. There are no other scientifically proven side effects. Now, this was just a little excerpt that was taken from the internet that was looking at the HPV situation in the US. And what stood out to me is that they're saying that one person every 20 minutes of every day, every year, gets cervical cancer caused by HPV. That's an important thing for us to really zoom in on. Every day, every year, there's somebody that's being diagnosed with cervical cancer or have cervical cancer and they don't even know that they have it. What is the age range that we're looking at in Guyana and the doses of the vaccine? We're looking to have the vaccine available for girls 9 to 13, but the vaccine can be administered to persons 9 to 26. In Guyana, the age group that we're looking at, as I said before, is 9 to 13. It is, however, most effective between 9 and 16 years. How many doses do you need? 2. At the time and 6 months later. That's if you're under 16. If you're above 16, then 3 doses are required. Why not the boys? In Guyana, I'm speaking about. Now, there are lots of reasons why, and I think one of it looks at, in looking at a broader economic picture, you will first try to look at your population that is most vulnerable, and then you move on to the others. That is what we're looking at right now. Who is most vulnerable, and then we include all the others. Right now, the girls and women are most vulnerable. So, if we do a very good job, which we will, by the way, and achieve at least 95% or more of the girls within the age group, it means that the boys of that age group will automatically be protected. I'll leave you to think on that one, so you can ask me questions later. I wouldn't explain that now. So if you have 95% of the girls vaccinated, it means that the boys of that age group will automatically be protected. Now, we had a pilot of HPV in Guyana in the year 2012 to 2014. That's when it was first introduced. And we received a donation of 21,600 doses. And we looked at girls 11 to 13 in regions 3, 4, 5, and 6. We started off with very high coverage, but that later fell for many reasons. One, the girls were mostly in grade 6 who received the vaccine, which means that some of them would have left their district and their region, and so follow-up was difficult, looking at the clinic perspective, and we would have depended on parents to bring them back to get the vaccine. 2, there was a very strong anti-vaccine campaign against the HPV vaccine that would have caused some of the fallout from the first dose for the second and third. However, we're coming back with a boom, and based on statistics of other countries and what we have on our own, we recognize that this vaccine is very important. The Technical Advisory Group on Immunization within the region has also advised all countries that HPV is the way to go if you're looking at preventing cervical cancer. It is very cost effective. If you look at the amount of money you have to pay for treatment of cervical cancer, and you look at the cost of the vaccine, which one is most effective? Which one is cheaper? And we not forget about the money. Look at the pain. Look at the losses to family. Look at the amount of children who will have to grow without mothers. Look at the husbands who will lose their wives. The mothers losing their daughters, and I could go on to the whole range, who lose their friends, who lose their best friend. It's a long, long, long list. And if you ever have the opportunity to speak to any patient who has cancer, it is a very, very painful road. Very painful. Imagine knowing, and the psychological effect of knowing that at some stage down the line you are not going to be here to see so many things. That is why we invited you today. This is a call on you as a person to recognize that this is very serious business. We have an opportunity to save our women folk. We have an opportunity for every girl to be able to become that doctor, that president, that whatever, by just a simple stick. You have the opportunity to assist us with getting this message across. And I consider that to be a very, very important task. As healthcare providers and as public servants, we're to serve the public. And we're reaching out to you this morning because your role is immense. You go much further than we can in most cases. So with that, I say thank you very much. And in the week of October the 16th is when we hope to have our countrywide implementation. Now there's just one more slide. What is our strategy? Immunization, because that population resides in the school. Most of the girls within that age are in school. So we will be working in conjunction with the Ministry of Education to immunize girls in school. We have already begun the partnership with our private pediatricians for mothers who do not want to take their child to have the vaccine in school, that they can actually take them to the pediatrician who will give them the vaccine. And for all girls that we cannot, especially in the remote areas or those who are out of school, to have outreach activities in the regions, in their villages, so that we can get every girl within that age group immunized.